Well, good afternoon. Can you hear me? Okay. Okay. Um, as a government employee, I'm not supposed to do commercial plugs, but I do need to correct. My son is a very good chef, but he's the chef de cuisine. He doesn't own the restaurant, so one of these days. I'm really privileged to have the opportunity to talk to you today about addressing elder abuse. I recognize that I am among the experts here. I think every expert in the field is represented at this meeting, and it's really, really impressive. What I've been charged to do is to talk a bit about the NIA and NIH vision with regards to this issue. And thus, I'll talk about things that we have done in the past, things that are ongoing currently, and what we envision to be the future. I think we all are interested in better being able to understand who would want to mistreat or maltreat lovely ladies like the ones that we see pictured here. Even worse, why would one of these ladies become someone who is mistreating an older individual? But as we all know, you can't necessarily tell just by looking. One of these sweet little old ladies could be one of those individuals who's involved with elder mistreatment. What we have done over the years have been to starting with what's considered now a landmark report on elder mistreatment done collaboratively with the National Research Center Council, and was published in 2003, a treatise on elder mistreatment, abuse, neglect, and exploitation. It was a meeting that helped us to set an agenda for the next many years, and we made an investment in particular in looking at methodologies to approach this problem. In 2010, we had a follow-up State-of-the-Science meeting here at the National Academies. I, in fact, got an opportunity to participate in part of that right around the corner here. It was, again, a meeting where all the experts were there, somewhat smaller than this meeting. But the objective was to summarize the state of the science in elder mistreatment, identify gaps in knowledge, elaborate on types of work needed to advance the science since the National Research Council report from 2003. And there were four major outcomes from that meeting. It was noted that we need interventions at all levels of the elder mistreatment, including prevention, keeping abused elders in their homes, providing clinical interventions, and legal and criminal justice interventions. We also felt that there had been a lot of progress made in measurement of elder mistreatment, but there needed to be further advancements in looking at national prevalence and incidence under the direction of agencies whose mission is closely aligned with those sorts of measurements, such as the CDC and the Department of Justice. We saw that financial fraud had been identified as a significant problem, and that there was too little research that had been conducted on determining its causes and looking at means of treating it. And we felt that there was a need for research in minority populations, in career development of researchers in the field, and certainly there was a need for more funding in general with regards to elder mistreatment. So that was the state of things in the past as of 2010. And so what is the current state of things? In preparation for this, our Office of Planning, Analysis, and Evaluation did a very extensive literature search for me and put together this monograph that's just the abstracts for projects that were published within the last year. There's a lot that's going on. What I will do is highlight a few things, many of which are NIH funded. And when I say NIH funded, not everything is funded by the National Institute on Aging. Many of our sister agencies have interest in this, but we're all under the umbrella of the National Institutes of Health. For example, the Family Care Conference on Elder-Focused, Family-Centered, Community-Based Intervention for the Prevention and Mitigation of Elder Abuse is a project that was reported in the Gerontologist back in 2007. This is a project that brought together families and got them to focus on concerns and align their efforts toward a positive action for the older individual. It was bringing an intervention that had previously been piloted in the Pacific to a Northwestern tribe and was found to be very useful. As I recall, that's supported by the National Institute on Nursing Research. It's an opportunity for us to look at disseminating something of that sort as well. Similarly, there have been a number of studies looking at detection of elder mistreatment and education about elder mistreatment in a variety of clinical settings. There's a Canadian study that looked at psychiatric hospital staff and tools that might be useful for detecting maltreatment in individuals with dementia. There's a UK study that looked at young physicians and what could be done to train them to detect problems with elder maltreatment. There have been studies looking at individuals in dental clinics. Dr. Fulmer's and her colleagues have a report in the Journal of Elder Abuse and Neglect looking at what might be a feasible means of efficiently evaluating for elder mistreatment in a busy dental clinic, and demonstrated that that is quite feasible, in many cases aided by computer interventions. And I believe at the time that this came out, it was the time that Dr. Fulmer was also being supported by the National Institute on Aging for the research. Researchers at University of California and San Diego also looked at interventions to increase the knowledge and self-perceived likelihood of reporting elder abuse in a population in a dental clinic. And then finally, a couple of studies supported again by the Nursing Institute looked at the role of critical care nurses and emergency room staff. The critical care nurse study did a focus group of nurses to determine how quickly and efficiently and systematically they evaluated individuals who were admitted to the intensive care unit for evidence for elder abuse. It appeared, based upon the feedback that was provided, that that is something that is done on a systematic basis, that the nurses recognized the signs and symptoms of abuse, but they were also aware of why the older person was reluctant to report that abuse, and that those are considerations that need to be made on a systematic basis if one's going to disseminate best practices. Similarly, in a study, again, supported by the Nursing Institute, Zeminski and colleagues looked at looking at indices for suspicion of elder abuse in the emergency room. They did a retrospective chart review over the course of many years and found that there were several cases in which there was a presentation of an older individual to the emergency room with upper extremity injuries, with open wounds, with contusions that would not be fully explained simply by a fall, and an opportunity to potentially train more emergency room staff to be sensitive to these issues, so issues with regards to elder mistreatment would not be overlooked. In terms of currently funded projects that are not necessarily I'm not necessarily talking about a publication at this point. We have a study by DeLima and colleagues looking at the impact of promontories in low-income Latino neighborhoods. Promontories are individuals who are specially trained Spanish-speaking community members, and they went about trying to identify elder mistreatment in these neighborhoods. And they found figures that were much higher than had been previously reported. Overall, approximately 40% of the Latinos that they spoke to, elderly Latinos that they spoke to, had experienced some form of abuse in the prior year. Approximately 25% had experienced some form of psychological abuse, almost 11% physical assault, 9% sexual abuse, almost 17% had experienced financial exploitation, almost 12% caregiver neglect. They found that abuse was physical, psychological, and sexual abuse was correlated with younger age, higher education, and experiencing sexual or physical abuse before the age of 65. They also felt that this higher prevalence of abuse that was reported was either due to the population being more vulnerable to such problems, or to their being more willing to disclose abuse to the promontories because they were part of the neighborhood, or perhaps a combination of the two. Another ongoing project is one being supported by Teresi and colleagues, and with a report in the Gerontologist just a couple of months ago. I think Dr. Lax and Dr. Pillamer probably talked about this earlier, so it's just reinforcement that they've done a beautiful job in developing an instrument to measure self-reported resident-to-resident elder mistreatment. And I really congratulate them on what they're doing in the city of New York with regards to elder abuse. Another ongoing project that we have is led by Shelley Taylor at UCLA, and she's looking at the bases for vulnerability to fraud. We know that older adults are disproportionately vulnerable to a wide range of dubious financial schemes, and the reasons for that vulnerability are not totally clear. And what they are doing is looking at psychological issues like social isolation, decline in the ability to determine that someone is being deceitful or that someone's untrustworthy, and at the same time looking at functional MRIs, and you see a picture there, example of how things light up on functional MRI, to see what parts of the brain are activated when challenged with various scenarios. The objective here being to get a better understanding on a neurologic basis as to what happens with these older adults. I guess ultimately, if we can figure out what parts of the brain are activated under these circumstances, perhaps we can train people to activate other parts of the brain. Perhaps there are medications that can be developed to target this, but it's kind of interesting and an exciting way of trying to approach the basic biology of the problems that exist here. And of course, we have Dr. Xin-Chi Dong's work with regards to the PINE study. We like to take credit for the fact that a small innovative grant from NIA on R21, which is not a lot of money, helped get started with the Chinese Health and Aging Project. As I think he probably shared earlier, they have developed a community-engaged longitudinal population-based study of relevant health issues of Chinese older adults. They've built a culturally appropriate and sustainable partnership. They've done a random block census of older Chinese residents, and they've examined linguistic and cultural barriers of studying relevant health disparities issues. So they're looking at a broad range of issues, and when I looked at this and looked at how little money we'd given him initially, I'd really take my hat off to him for that. He's, of course, successfully gone on to get an R01 from us, an R01 from the Minority Health Institute, and is doing lots of wonderful things. Some of the initial findings from the study relate to elder mistreatment. They found, somewhat similar to the study looking at the Native American population that I mentioned earlier, a higher prevalence of elder mistreatment than had previously been reported. Some 24% of the participants mentioning some form of abuse, 10% of them having psychological abuse, 10% financial abuse. Of those who were abused, almost a third of them having experienced violence prior to the age of 60, whether that's intimate partner violence or child abuse. So some parallels there. And again, perhaps because it's a community-engaged sort of study, there are higher rates of reporting of abuse than might be the case in other situations. And your other co-chair for this meeting, Dr. Campbell, has a training grant from the Health Disparities Institute to provide interdisciplinary training on preventing and addressing violence in families. The purpose of the program is to train nursing, public health, and medical scholars in the science of risk factors and interventions for physical and mental health problems. They're conducting policy and practice relevant to epidemiology of violence. They're looking at primary, secondary, and tertiary prevention. And one of their clear aims is to look at issues related to elder abuse. So it's really rather exciting to see how much is going on at NIH-wide to address issues with regards to elder mistreatment. And this is really just in the last couple of years. And if you go further back, there's much more potentially to be discussed. But then the question is, what do we want to do for the future? And I'm going to stop and ask, I see a lot of young faces out here. How many people know what that object is that I have in the upper right-hand corner? For those of us who are boomers and older, we know what that is. For those of you who I see who are younger, that's called a Rubik's Cube. And the point of that being there is to demonstrate that this is a complex problem. The Rubik's Cube, the goal of it was that you're going to align all the colors in one row so it's all uniform. It's very difficult to do. And this issue of elder abuse is, I think, similarly complex. I understand you had quite a bit of discussion about theoretic frameworks to approach this. But, you all know this. I know I'm speaking to the choir. What are the characteristics of the victims? What makes them vulnerable? Is it cognitive impairment, psychological distress, social isolation, low income, need for assistance with their basic activities of daily living, their premorbid relationship to the abuser? How could it be that one of those sweet little old ladies that I showed you in that first slide could be as much of an abuser as someone who, you look at and say, oh, yes, that must be an abuser. And many times it's not. What are the characteristics of the perpetrators? What are the red flags? Substance abuse, mental illness, dependency, unemployment. It gets further complicated by the fact that there's so many different types of abuse: physical, sexual, psychological, neglect, financial exploitation, so many different settings in which it can take place. Home, residential, care facilities, community. And as I understand, you also talked about there are cultural differences as to how the problem may be perceived in terms of tradition and values. So that makes the challenge for the researcher in the field particularly great. And it's like trying to solve a Rubik's Cube puzzle from my viewpoint. Nonetheless, we know that the need is great. We know that at least 1 in 10 older adults has experienced some form of elder abuse, and that percentage probably is higher because people are reluctant to report. We know that it's associated with increased risk of mortality, increased risk of emergency room visits, hospitalizations, nursing home placement, loss of independence. There's a lot that's going on. From the NIA perspective, National Institute on Aging perspective, we are particularly interested in the risk factors associated with financial abuse. We feel that this is an area that's been under investigated. We feel that there could be some synergy with the investment that we have in our research with regards to behavioral economics and our demography centers, et cetera. And there are a number of things that are ripe for that research. We have progressively increasing wealth in the elderly segment of the population, current cohort of olders being benefiting from employer-provided retirement plans, us baby boomers as we age, hopefully retiring with a 401k and not a 101k. We'll see what the stock market does with us. But much more in the way of wealth than has been the case in the past, and therefore potentially at risk. For that segment of the elderly population that is dependent upon Social Security, small losses of income can be really perilous, so it's even more of an issue for that segment of the population. And there are both psychological and neurobiological changes that occur with aging that can make people susceptible to fraud and financial abuse. Depending upon the setting, the individual can make really good decisions or they can make really poor decisions. And beyond the process of decision making is the issue of being able to determine whether a source can be trusted, whether it's an individual or information that's being sent to them. And then certainly for that segment of the population who have true pathological cognitive decline, and that's based upon what our neuroscientists are telling us, going to be as many as 1 out of every 2 individuals 85 and older. These individuals are certainly potentially vulnerable to financial abuse. So we think that it's an area to focus upon. You see the data from many of the researchers at least 2 of the 3 researchers who you've heard from earlier today about the prevalence of financial abuse. We heard from the NAS panel in 2010 that it's an area that needed additional research. We've had some conversations with the Administration for Community Living and the Consumer Financial Protection Bureau about potential collaboration. such as improved longitudinal measurement in existing surveys. And we have a number of such surveys that could potentially serve as the basis for looking more carefully at these sorts of issues. For those people who are interested in initiating their own research along these lines, I will remind you that most of the money that goes out of NIA and NIH as a whole goes to the individual investigator who has, in an unsolicited fashion, initiated an application. For NIA, some 60% or so of our grant funds go to those sorts of individuals. The NIH average is about 50%. So if you have a good idea and it gets well reviewed by our peer review panel, you will likely get funded. As we were talking during the break, that's likelihood of getting funding is getting a little tougher these days, but still, there's a lot of money there and a lot of opportunity for people to get funded. I'll also remind those of you who look young out there in the audience that we still give extra consideration to early stage and new investigators, depending upon the institute, a 3 to 5 point advantage. So this is the time to jump in. But this is a field that really requires an interdisciplinary approach. And one of the things that you might want to think about is a conference grant, an R13, which would bring together people from multiple disciplines to allow them to talk and think about how they might approach a research problem related to elder mistreatment and maltreatment. And those are available in just about every institute and center at NIH. And then finally, I'll mention that we do have some centers that might be good places to focus on when thinking about elder maltreatment issues. In particular, our Edward G. Roybal centers, which are meant for translation of research from the bedside to the reality of the world. And as more data comes out with regards to elder mistreatment, the Roybal Center might be a means by which some of that could be translated. I don't mean to say, however, that NIH is the only government institute that should be focusing on these issues. It is something that needs to be approached in a collaborative fashion, and I show here the logos for some of the government entities that are already involved, and there are many more. The Administration for Community Living, the Centers for Disease Control, the Department of Justice, I mentioned the Consumer Financial Protection Bureau, and there are others. We need stronger evidence for a policy base, looking at prevalence data, characteristics of the abused and the abusers and the settings in which occurs, proven interventions and considerations of cultural differences. We need more and improved education and training. We need to be clear as to what the content should be, how to, things such as what is elder abuse, how to identify it, prevent it, and what to do when it's suspected or confirmed. And we need to get out to the audiences who need to hear this, the families, the medical professionals, ombudsmen, community members, adult protective services workers. And finally, we need some really good, strong program evaluation that can assess the success of interventions and identify ways to improve them. So I'll close by just reinforcing that the issues are complex, and I really salute everyone who's out there trying to make a difference, because ultimately we want to allow everyone to live to 100 plus, as this lady who's wearing her 107th birthday necklace represents. The need is great, and it needs to be a collaborative process. And we at NIA and NIH really are happy to be part of that team that's collaborating. So I'd be happy to answer any questions you might have.